Good morning. I want to welcome everyone back to day 2 of the ACHDNC August 2023 meeting. Before we do roll call, I want to reintroduce an individual that many of you know very well. Cindy Powell is serving as the new organizational representative for the American College of Medical Genetics and Genomics. You probably remember that Cindy is professor of pediatrics and genetics at the University of North Carolina at Chapel Hill at their School of Medicine. She's a board certified clinical geneticist, cytogeneticist, pediatrician, and genetic counselor, and is the immediate past chair of the ACHDNC and a member of the board of directors of the American College of Medical Genetics and Genomics. So welcome back, Dr. Powell. You didn't stay away very long, and we're happy to have you. I don't know if you'd like to make a comment or two. Is she?
Hello.
And if you don't, pardon me?
Oh, there she is.
Okay.
Hi, sorry. Sorry about that. Hi, everyone.
Thanks for rejoining us and continuing to support the work of the committee. That's super.
Nice to be back and see a lot of familiar faces. Thank you very much.
So with Cindy being back, we're going to just kind of move forward. Today, we're going to begin with the presentation from Dr. Hautrow on focusing on equity after newborn screening. We'll then have public comments, and after a break, I'd like to just quickly review the documents I sent out last night, trying to capture the additional information and ideas around expedited review. I tried to provide it to you in 2 formats, kind of a narrative document and the slides with the edits we discussed. And then we'll move on, hopefully, to talk about Krabbe and whether or not we would like to move it on in the expedited review process. And I'm going to turn things over to Letitia, who will do roll call. And then Dr. Kemper in his, Dr. Hautrow will begin her presentation. Thanks.
Great, thank you, Ned. From the Agency for Healthcare Research and Quality, Kamala Mistry.
I'm here, thank you.
Michelle Kajana.
Good morning, here.
Cynthia Hinton from the Centers for Disease Control and Prevention.
Here.
Janine Cody.
Here.
From the Food and Drug Administration, Paula Cappuccino. From the Health Resources and Services Administration, Jeff Brosco.
Here.
Jennifer Kwan.
Here.
Ash Law.
Here.
Sean McCandless.
Here.
The National Institute of Health, Melissa Parisi.
Here.
And Shanika Ponpatkun.
Here.
And for our organizational representatives, the American Academy of Family Physicians, Robert Ostrander.
Here.
From the American Academy of Pediatrics, Karen Downs.
This is Karen. I'm from AmChip.
Oh, AmChip, my apologies.
And this
No
is Debbie
worries.
Friedenberg, and I'm from AAP, and I am here.
Yes, got it. Thank you for the correction. From the American College of Medical Genetics and Genomics, Cynthia Powell.
Here.
From the American College of Obstetricians and Gynecologists, Stephen Ralston. From the Association of Maternal and Child Health, Karen Downs, thank you. From the Association of Public Health Laboratories, Susan Tanksley.
Here.
From the Association of State and Territorial Health Officials, Scott Schoen.
Here.
From the Association of Women's Health, Obstetric and Neonatal Nurses, Shakira Henderson. From the Child Neurology Society, Margie Ream.
Here.
Department of Defense, Jacob Hogue.
Here.
From the Genetic Alliance, Natasha Bonham.
Here.
From the March of Dimes, Siobhan Dolan.
Here.
From the National Society of Genetic Counselors, Erica Wright.
Here.
And from the Society for Inherited Metabolic Disorders, Susan Berry. Okay, and I am just briefly going to go over, remind folks about conflict of interest. Please note that you must recuse yourself from participation in all particular matters likely to affect the financial interest of any organization with which you serve as an officer, director, trustee, or general partner, unless you are also an employee of the organization or unless you have received a waiver from HHS authorizing you to participate. As in the case today, when a vote is scheduled or an activity is proposed and you have a question about a potential conflict of interest, please notify me immediately. You can email me at lmanning, so LMANNING at HRSA.gov. Thank you, and I turn it back over to Mitch.
Hi, Letitia. This is Christine Dorley. I didn't hear my name called,
Yes,
but I'm
thank you.
present. Thank you.
Thanks, everyone. I did, as I was listening to the roll call, just wanted to pause and give a shout out to our organizational representatives. Your attendance and participation is so greatly appreciated. We know that we make you sit for long times on Zoom calls or in meeting rooms, but it's so key to have this two-way communication with the organizations and viewpoints that you represent. So thanks for attending and thanks for being here for day 2. Moving on, it's my pleasure to introduce Dr. Amy Hautrow. Dr. Hautrow is a professor and endowed chair in the Department of Physical Medicine and Rehabilitation for Pediatric Rehabilitation Medicine at the University of Pittsburgh School of Medicine. She is also the vice chair for Quality and Outcomes and is the chief of Pediatric Rehabilitation Medicine Services at UPMC Children's Hospital of Pittsburgh. Dr. Hautrow's main clinical focus is caring for children with disabling conditions and helping to improve function and quality of life to the greatest degree possible. Her patients include children with spina bifida, cerebral palsy, rheumatologic disorders, brain and spinal cord injuries, and orthopedic, musculoskeletal, and neurological disorders and conditions. Complementing her clinical focus, Dr. Hautrow's research focus is on childhood disability trends, advancing health equity, and developing channels to improve service delivery. I'd like to turn things over to you, Amy, and thanks so much for joining us.
Well, it is a distinct pleasure for me to be here. And just for everyone, I'm going to do a visual introduction as well, in case we have anyone on the call with vision impairment. I'm a pale woman with shoulder length, dark brown hair. I'm wearing bright yellow today, and I have black glasses on, and there's pictures of animals on the wall behind me. I get the distinct pleasure of speaking to you all about the issue of equity as it relates to what happens after newborn screening. I will start off just though with a couple of disclosures. I have quite a lot of grant funding. None of it relates to heritable disorders, and so no actual conflict. I'm going to speak to you about thinking about equity. So to do that, I want to just make sure everyone's kind of on a level playing field with some definitions. I know that many of you know these inside and out, but if they're new to other people, I think it's really helpful for us to just level set. And I'm going to review some issues around access to care. And we're going to pay special attention to children who come from minoritized or otherwise oppressed backgrounds. And all the while, I want us to be thinking about, in our own work, how do we engage in the work we do with a health equity lens? This is just stage setting, because all of us in the work that we do have growth potential, myself included, around how we approach and design and develop programs and services in such a way that it optimizes health equity. So health equity, that just means that everyone has a fair and just opportunity to be as healthy as possible. So fair and just, and it's focused on this opportunity. And it's very process-based because it requires us removing obstacles. So that is obstacles such as the root causes of health disparities, poverty, and discrimination, and then all of their downstream consequences. And these are really about lack of access to the things people need. So when we think about health disparities in the lens of health equity, we recognize this as differences in health or its key determinants that adversely affect those that are marginalized or oppressed. And the process towards health equity is the actual reduction in those disparities. So I love a good picture. And so I put this into an upstream, downstream graphic for you. So I just mentioned poverty and discrimination, and all of the kind of political, and I'm using the word political because there's policies that derive, I'm not using the word partisan, our access to things like housing, finance, employment, and those things. And all of those are amenable to policy interventions, because what we recognize is there's a lot of issues here. Housing and food, instability and insecurity, lack of stable employment, lack of good education. And then in the world that I swim in, right, the lack of access to services and supports that promote health. So if we have this baby who just had their newborn screening, we don't want them out here in the open water. We want this baby to get all the supports it needs to travel the journey through life as healthy as possible. So you heard me say the word minoritized before, and I think it's just important that we own how deeply structured racism is in our culture, society, policies. And so structural racism is the totality of ways that society fosters discrimination or oppression. And it's all those different things that I just said. So systems that limit access to housing, good education, employment, earnings, all of those things are mutually reinforcing. I know everyone's really familiar with terms around racism, but I'm guessing people know basically about classism, but not really so much how it operates. And it operates in conjunction oftentimes with racism and other sources of oppression. So it is the systematic oppression of people who are disadvantaged based on their class or financial worth. And what happens here is that the policies and the systems and practices are repeatedly in this circular way to benefit the upper classes by keeping or oppressing people below them. And it is, of course, held in place by a system of beliefs and cultural attitudes that really see people who are poor as less worthy. And we have this all over the US. Ideas like, well, in America, all you got to do is lift yourself up by your bootstraps, right? And you can't actually lift yourself up by bootstraps. That's the whole point of the phrase. And so the ridiculousness of it is if you just work hard in America, you can be the next millionaire, when all of these kind of structures are set up to not allow that to occur. And this is really important because kids often live in poverty. So what I'm showing you here is over the last 20 years, and this is when the Great Recession happened. So I grayed this out. We saw a massive increase in childhood poverty. And this line here is the all children. So I'm showing you this by race. And what's really concerning here is there's a big differential. So white children are less likely to be poor, as are Asian children, than Hispanic children and Black children. Okay, this is not just a little difference. So all children, nearly 10%, to 27.7% among Black children. So we're talking about essentially 3 times the rate of poverty. So I told you that poverty, classism, and racism also often go together. They also often go together with ableism. So ableism is that same sort of thing that we've been talking about. The stereotyping, the prejudice, discrimination, oppression but this time not by race or not by income, it's towards people with disabilities, where people with disabilities are thought of as a diminished state of being. So whether it's the ideal physical state or cognitive state, people with disabilities are deemed less worthy. And I put up the ICF because I really love how this neutralizes language. But what I can tell you is like all that stuff when I was showing you the upstream and downstream, the international classification considers them environmental factors. And of course, they interact with our own personal choices and beliefs and desires. But it's really important to recognize how incredibly essential it is to understand the environmental context. So those social and political determinants of health. So why am I telling you this? So babies who show up with a positive newborn screening, are heading down the path to being children and youth with special healthcare needs. So they are more likely to be poor and they are more likely to be minoritized. So this is just an income breakdown. So these kids are living below the federal poverty level. These kids are, their families are quite well off, above 400%. And what you can see is just this big, huge number here, minoritized Black families, and Native, Hawaiian, and Pacific Islanders. So many more of those kids with special healthcare needs are living in families that are poor. So I am certainly not an expert in newborn screening, but I do see a lot of kids in my practice who have the disability consequences of sickle cell disease. And, this means these kids have been kind of undermanaged for a long time, that we're ending up with these adverse disabling consequences, such as related to multiple repeated strokes. So we know, obviously, sickle cell disease has a strong hereditary component based on like racial grouping, so shared ancestry. So we know these kids, these African-American kids, just are more likely to live in poverty, and they're more likely to experience the consequences of racism. So I think it's really relevant as we think about our successes in identifying a disease versus our successes in helping children thrive and have the optimal health when that disease is identified. And of course, we know that there's a lot to be done to improve care for individuals who have sickle cell disease. And certainly I see that in my own clinical practice. I also see a lot of kids who have failed newborn hearing screen, but often get lost in the shuffle of follow-up. And there's been, and I pulled this from the Maternal and Child Health Bureau website, there's been a lot of achievements here. So really, we were doing terribly in terms of getting kids screened. Now, basically all the kids are being screened. So this is a big, big win. So like 97% of infants, that is a hip, hip hooray. But what is not a hip, hip hooray is that there's a hefty portion of them that are just not getting the evaluations and follow-up that they need. And what do we need to do for kids who have identified hearing impairment is we need to get them engaged in services. And we know the earlier you intervene, the better things are. And there's this time window from when children, infants leave the hospital and they have this like just robust opportunity for us to intervene on their behalf. And so often that intervention does not occur. And guess who that intervention does not occur for most? The children who come from oppressed and minoritized backgrounds. And these are the kids that really need to get access to high quality healthcare, but just are not in the same way. So I'm going to share a bunch of data points, and these are all from the National Survey of Children's Health. And you can actually go to childhealthdata.org and run these same kind of different analyses. So as you guys know, the Maternal and Child Health Bureau has identified systems of care, 6 activities that identify that kids with special healthcare needs are getting care in a well-functioning system. So first of all, I just have to say, overall, our ability to do this for kids is craptastic. So this is like not even 14% of kids with special healthcare needs get it. But you know what, the ones who do are the kids who are white, and the kids who don't are from the minoritized backgrounds. So even though we're doing not well overall, we are doing less well. So this is one of those opportunities for health equity. This is where we try to think about what things would make it more likely that these kids, these oppressed kids, could get what they need from the system. So again, I'm going to show you, this is this time by family income. The lightest green here are the kids in families who have the least amount of money. The darkest green is the families who have the most amount of money. And again, overall, we're just not doing so well. That's the same line that I showed you on the previous slide. But of course, who's doing better? Kids who come from more well-off families. Who's doing worse? These kids who are living in poverty or near poverty. And, you know, I couldn't even create a better stepwise relationship between income and care in a well-functioning system than the one that it already shows up in the data, but just tells us we are so desperately needing to do something that helps the kids that need the things the most get the things that they need. So when I think about the kids that I care for, and many of the children who come from the world of newborn screening, is the kids who have more complex healthcare needs. So in this graphic, I have kids who are less medically complex. Their healthcare needs are relatively easy to manage. And these kids are the ones who are more complex. And of course, that same line would be here of the 14%, less than 14%, because that's the baseline line for care in a well-functioning system. And I want to rephrase this into this is opportunity. So nearly over 80% of kids who have less complex healthcare needs have an opportunity to have better care in a well-functioning system. And that opportunity is even bigger for the families of kids who are more complex to be able to get the care for their child that they need. And some of the core things are just like how we engage with families. And so I just wanted to share family-centered care by income. Again, this other stepwise relationship. So basically, family-centered care is that you feel like a partner. Your providers respect your values and understand your goals, that you're not in this kind of like top down, that you're engaged in the discussions about what happens next and what you want for your child. And you know, well-off families tell us they get that. And very luckily, over 85% of families report this overall. But again, this ridiculous stepwise relationship where the kids we need to provide the most services to in the best way are just not, their families are not reporting that service. And also by minoritization. Again, we look pretty good overall, but it's the white families who report it and our marginalized families who do not, which really says that there's an opportunity here. And one of the hardest things is moving from a screening to a full evaluation and treatment. We have a lot of drop off. So not just in the newborn screening space, but also in the screening for developmental concerns in the primary care pediatrician's office, for example. And one of the things that families repeatedly tell us, and it's illustrated in the National Survey of Children's Health, is how frustrated families are at getting care. So I have combined the more complex, less complex kids with special healthcare needs with the income and with racial differences by minoritization. Well, for the kids who have the more complex conditions, right? Many of these kids who show up with newborn screening identified conditions on their screening, their families are reporting they have frustration getting care. So I work with kids who have neuromuscular disorders, and these are things that we genetically know about, and although we have systems that are set up, multidisciplinary programs, still families whose kids are more complex are just reporting they're so frustrated getting what they need. And also it's real consequences for their families functioning. So families also report that they have to cut back on work to just meet the needs of their child. So more families who are poor are reporting that they have to cut back work than families who are well off. Okay, so who needs the income the most? The families with the least income, right? These are the things that just drive me totally bananas and upset, because these are the things that I recognize that we need to address to make sure that families are functioning well, kids are getting what they need. I don't even need to show you the next slide. I will, about what it looks like by minoritized race in terms of having to stop and cut back work. But you know who it is? It's our minoritized families who are doing that. So just the kind of services, and if we think about it really robustly, these families are not getting what they need. And they often report to us that they have trouble paying their medical bills. If you cannot pay your bills, you often do not seek care. So again, I kind of layered these all into one slide. So this is the colors you're familiar with about income. These are the minoritized groups. And then this is by complexity. So families who have the more complex conditions, heritable disorders like muscular dystrophies or sickle cell disease are really reporting trouble paying their medical bills. It also really relates to insurance as well. But I want to tell you like a couple of stories. And because I think this is some of the things where we put on our health equity eyeglass lenses, right? And we start to see how things are set up and are operating, then it feels like we have opportunities to shift, right? Like what are the unintended consequences that end up hurting people who are already oppressed, limiting their options? So I'm going to give you an example of attendance policies. So let's say you're a parent of a child and you need non-emergency medical transportation for your child to get to their therapies or to their evaluations or to the doctor. Okay, so non-emergency medical transport is great, but it's super challenging to use. So it provides you a 2-hour window usually for pickup. 2 hours, right? Like that's not how I plan my days with this like big lag time of 2 hours. Also, by the way, it's frequently late and occasionally they cancel at like the very last minute where you wouldn't even have time to make other arrangements. So what happens is that the providers on the other side are like, oh my gosh, another no-show. Oh, you didn't even call us, tell us they couldn't come. Like they don't. And then we get into all of these ridiculous thoughts. They must not really care about their child's health. I mean, there must be, oh my gosh, they're so disrespectful and lazy. And that is all because of the way the system is set up to operate. Now, no one is telling us that because they don't come, we should think of them poorly, but we know we all have these biases and we're all functioning in this world where when someone doesn't come, it's problematic for how we run our services. And so when I think about the non-emergency medical transport issue, first, it really sets up this dysfunction as it relates to things, inside visits, but it also like primes all of these things that these unconscious biases that people have that lead to like long-term poor consequences as they capitalize and build on each other. And in addition, we're just not structured in a way that we have policies and strategies to get these families what they need. So if I'm working shift job, but I have to take an additional 2 hours off just because I can't trust that they're going to come when I need them to come, that's 2 hours of income that I don't have. And if I am a person living in or near poverty, that 2-hour income could be the difference between paying my electricity bill on time, right? So, and this over and over capitalizes and grows so that families are really shoved into this rock and hard place situation where their choices just are not tenable. And we as providers start to think, well, they're so irresponsible, when it's not that at all. So when I think about attendance policies, it's often something like, 3 strikes, you're out. You don't show, you come late, you don't get the care. Okay. Or if you come a half hour late, oh, too bad, you showed up, but we're not going to see you. We all know that these attendance policies are not set up to be punishing, but they end up being punishing. And, as overhead is expensive and clinics want a lot of throughput, one of their solutions is a 3 strikes, you're out policy. But who does that impact? When care is foregone and transportation in this example is a problem, I can tell you exactly who it impacts. it impacts the kind of kids who showed up as a positive newborn screen, kids who are more medically complicated. It shows up, it's impacting the kids from minoritized backgrounds. It shows up in families who have limited financial resources. So why is it? So it's the poor families who report it the most. And we have to really understand it's like this why is a complex why. And the conclusions that we jump to are not always the right conclusions. And the way that impacts children and their families long-term can be really detrimental. So when we put on our health equity glasses, we really need to recognize that there's a lot of injustice baked into the system. There are biases that we all hold on to, and that lead someone like Martin Luther King Jr. to say, of all the forms of inequality, injustice in healthcare is the more shocking and inhumane. And so for us, it's a call to action to say we got to change the way we do things so the kids get the follow-up they need. They get the services they need. Those services are easy to access, are family-centered, meet their needs, give them what they deserve so that they can be as healthy as possible and achieve health equity. All right, guys, I think that my time is up. So I'm going to stop the share of my screen so we can move on to the next portion.
Thanks so much for your time, Dr. Houtrow. That was just super. And I describing it the way you did was exquisitely done. I do a lot of health equity work. That's what I was doing before I came back over to the health department and the School of Public Health. And I think applying the same issues that we see at all ages in terms of challenges to equity applied specifically in the area of newborn screening is just very helpful to this committee in thinking about moving forward. So thanks so much for your time. We're going to start out with discussion, and as usual, I will call on committee members first for questions or comments, and then we'll turn to organizational representatives. And first up, I have Jennifer Kwan.
Hi, I'm Jennifer Kwan, committee member. That was a wonderful talk. As somebody who directs a neuromuscular clinic, I feel like I live a lot of the issues you describe. And so, of course, I am impatiently thinking about solutions. I do really appreciate you bringing these things up. I also want people to know that I think the greatest source of health equity is our medical system. You know, the medical system that we live and work in is really the biggest barrier that I fight in terms of trying to get people care. So I'm interested in your solutions, and I also like to highlight, I think, what are 2 points, key points for me, which is that newborn screening can improve diagnostic health equity in terms of allowing children who have serious disorders to be identified in a timely fashion. But it may not result in the improved outcomes that people hope for without real improvements in our existing structure of care. But anyway, thank you.
I really love that. And I think that your point is so well taken about, like, we have done so much to improve equity in diagnosis because it's a universal, right? So we're capturing almost everyone. But universal things don't always work as well for all groups, right? Unless it truly is fully universal, it's really, you will have these inequities. And I think we should celebrate the achievements like universal screening, but then recognize that where we have to move the needle in the actions we take are different for different groups. And I mean, I didn't mention rurality, but rurality, coming from a rural locale to try to come to a multidisciplinary neuromuscular clinic, that's a huge undertaking, right? And I think our kind of attitudes around what we expect families to be able to overcome are just unfair to families. Our health system is not structured in a way that is easy to use and navigate. You know, I have chronic health conditions. I've had them my whole life. I have been a user of a high amount of healthcare my entire life. I'm a doctor. I have a PhD in medical sociology and an MPH in health policy and management. And I struggle to assure that I have adequate access to the care that I need, right? Just imagine what it is like for families who don't have the capacity or the ability to navigate the way that I do, because I work in a health system. And so I think we need to be thinking about what it means for us not to be a simple work that we do for ourselves, which is hard work, but needed and work about how we perceive when families don't show up or follow-up is lost. And then also, what are the mechanisms by which families will tell us what would help them get to the appointments, right? Like, we need to build the equity activities with the people who will benefit and need those equity activities. So like me just sitting here typing on my computer and Googling things, that's not the same thing as engaging families and people with disabilities and chronic health disease in the planning of the activities that they need so that they can get the care they need. There's so much inequity in healthcare, so many opportunities, but like we need to really, for my big solution point is that, and the disability rights movement talks about this, nothing about us without us. Like, why don't we go to the people we need to help to figure out how they need to be helped?
So what I'm hearing you saying is engage with my population. So actually, and I think that's wonderful to really talk with people who are living it and then take their words to people who can make the changes. Thank you so much.
Thank you so much.
I really appreciate you mentioning rurality. You know, from Colorado, that's a daunting task for many of the families whose children are identified through newborn screening. And I know Sean can talk to that because he lives it daily, as do others at the Children's Hospital. So thanks for lifting that up. We have about 20% of our population that lives in rural or frontier areas where access to care, especially specialty care, is just not available. It's challenging to travel. So thanks for mentioning that. Let me turn now to Cindy Hinton.
Hi, Cindy Hinton. Thank you so much for that. As a fellow medical sociologist, really appreciated that. And the one thing that it really brings up for me, and that I think is so also baked into our system, is the expectation that is put on people that they need to make individual solutions to things that are environmental problems. And I mean, you see, I work in public health. It's like you see that in public health. We are really, as a society, geared towards how do we help you, family, person, make these changes to improve your health, when so much of it is totally out of an individual's control. And when you compound that with the inequities that are laid out in terms of complex care, it really is just stunning. I mean, no solutions offered here. I just really appreciate your presentation, and encourage us all to really think further upstream when we're looking for solutions.
Yeah, I think that hits the nail on the head. By the way, I love your wallpaper. I think that this individual solution thing, right? That's really how healthcare operates, but it should not be how we think about optimizing health for a population, right? So all of the people that live here and are, really kind of rugged individualism attitudes in the United States that are deeply embedded in how we think about ourselves as a country and a people, ultimately don't end up serving communities so well, and pit one individual's needs against another in kind of a very detrimental way. And the thing about health equity is that when our society collectively achieves more health equity, that's better for all of the things that we might want to do as a nation. And so it's not about like, oh, I'm not going to get so much of a piece of a pie of whatever service it is. It's about really understanding that when we all are healthier, right, especially people who are most at risk for poor health, are that we as a society function better, and that it's a value to have health in our society, not just a value for certain subsets of people. And I appreciate that there aren't easy solutions, but I think as a professional, I'm doing the day-to-day work with my patients to try to help them be as healthy as possible in my clinic as a doctor. But I'm also thinking, what are the things that we need to be changing? And your term upstream really, feels unsurmountable, but things are only unsurmountable if we deem them to be unsurmountable. And I think we have real opportunity collectively as organizations, as people in the field on the ground, to kind of work together for collective action.
Christine?
Thank you, Dr. Houtrow. And I must say that I love your glasses. Being a fellow glasses wearer, I'm always looking for new, exciting frames. But anyway, I wanted to ask, I know many newborn screening programs are incorporating additional testing, like molecular services, to try to improve health equity and time to diagnosis. And we are in the age now where long-term follow-up is becoming more and more developing and creating those types of programs. So I just wondered, what thoughts do you have for programs that are developing long-term follow-up that we can promote health equity in those programs for those infants that are identified by newborn screening?
I think one of the things that often happens is we're like, oh, well, we should monitor the social determinants of health and collect that information. And that's great, totally smart to do if we are willing to intervene on it, right? So if that changes, that we don't just give everyone the same thing. So collecting the social determinants of health information can help tell you where your choices for intervention may need to be different, may need to be amplified, may need to be repeated. So it'd be so much easier for my families that use non-emergency medical transport that if that service actually was robustly funded and got the families what they needed in a way that meant that they could keep the appointments and that they didn't have wage loss, right? There's things like FMLA, for example, that when you have 3 part-time jobs that are shift jobs, you don't get any FMLA. So recognizing the realities of families' lives will help tailor the kind of interventions that you need to do to get them what they need. So maybe what they need is not to come into the office, but for someone to go to them. Maybe what they need is co-located services in a way they haven't been co-located before. Maybe what they need is, like, once they have been recognized as income eligible for one program, they automatically get enrolled in all of the things for which they would be income eligible for, right? There are things that we could be thinking about. And then, in a world where that automatic enrollment doesn't exist, right? Even in the healthcare space, we know things like housing impacts health. And obviously for kids, nutrition impacts health. But how much time do we spend assuring these families are getting actual nutrition? I sometimes write prescriptions for food for kids because I can medically justify it, but I shouldn't have to do that, right? We should have structures in place. And when we're thinking about families that are marginalized and are vulnerable to the effects of poverty and discrimination, those are the places where I think we tailor when we discover them. And then we work extra hard at trying to kind of undo the systematic way these things are operating.
Jeff?
Thank you. All know that equity is one of the 4 pillars of the MCHB strategic plan, and it's one of the 4 cornerstones of our blueprint. In fact, Dr. Houtrow was the first author on our blueprint equity paper. And I just wanted to remind folks, we talked a little bit about this at the May meeting, and yesterday Ned mentioned our Propel and Excel grants, and we also have announcing the co-Propel ones that are coming, the NOFA will be coming out soon. What we talk about in that is in newborn screening, how we're thinking about equity is that we want to, as Christine just mentioned, start looking at longer term outcomes. And even if that's just at age 3 and whether children are thriving and families are doing well, and we're asking that states begin to start thinking about how to report that data, and whether it's in EDDI or in other worlds, not just as the across the board, how everyone in the state is doing, but also then disaggregating the data based on whatever the historically underserved groups are in that state. So whether it's rural residents, race, ethnicity, limited English proficiency, a variety of things. And then the states can then say, what's our strategic plan for making sure that all groups are getting to the highest level? And states aren't asked to be doing this alone. We also have a whole range of grants that are blueprint specific. I'm not going to go through all of them now, but we recognize that the issues that might be for a child with cystic fibrosis or sickle cell are probably not that different as they are for a child with spina bifida or cancer. So trying to work at a state level to improve systems of care is another key part of this. So just want to let you know that we are thinking about this, working on this, and so grateful to have Dr. Haushaw present today.
Thanks, Jeff. Bob.
Thank you. Robert Ostrander, AAFP. I have three brief comments, and two of them have been covered some. I would like, first of all, though, to talk about the fact that you pointed out that newborn screening can improve equity, but I wonder if equity should be one of the things that we consider when we're looking at nominations. For example, as you were talking, I did a quick literature search and found an article from March of last year that showed the difference in time to diagnosis from symptom onset to diagnosis and treatment by race and ethnicity, and it was significant for Duchenne muscular dystrophy. So should, as we consider Duchenne muscular dystrophy, adding it to the RUSP, should we consider the fact that using newborn screening would reduce that equity? So that was one question / point. The other comment, and it's been brought up some, but I'd be interested to hear you, Dr. Haushaw, speak somewhat boldly and specifically about systemic solutions. There are a lot of DEI sort of talks at most meetings that I'm part of now, and they all seem to be focused largely on convincing us that there's a problem. And I think we all kind of know that, and I'm appreciate the data and the talk. But what are the systemic solutions? And be bold with your thoughts about that, I guess, would be my second comment. And my last comment is rural health is a big part of my world and what I do. Although it says New York, I'm from Western New York in the middle of farm country and lots of Mennonite folks. And the rurality issue is a big one, but yet it always seems to be a footnote to these things, or not brought up at all. I don't see the data, and when I bring it up at meetings, honestly, I sometimes get pushback because, at least in our area, the rurality issue, there's white people. And anytime you start to bring up the possibility that there may be this sort of thing going on with white people, sometimes you can get pushback and feel like we're culturally appropriating or something. So I would love to see more data on the rurality issue, and also just people to be aware that pushback on that is not necessarily appropriate.
I think that's a super important point. And we often see maps that divide things by states, right? But that doesn't still get at the rurality thing. And then we see, and I think there is definitely ways to look at data from, how far away you live, geocoded, with more finesse than, what the data that I showed today. And I think it is really important to acknowledge how much of a barrier, distance to care can really mean. And your point about delayed diagnosis by marginalized racial groups, man, it's really profound. It comes up in kind of every kind of diagnosis that there is. I mean, things like autism, delayed diagnosis by years, and that delay in early childhood could be really detrimental for improving outcomes for those kids and this added stress that creates for families. And you're so right, as we often talk about, like, here's a problem, can I show you the problem? But don't talk so much about solutions. So you said be bold. In our health equity blueprint that Jeff was just talking about, we made points in that about we could reduce child poverty by 50%, sustain a reduction in child poverty, and have that be financially beneficial. So the NAM, with the National Academy of Medicine, which was the Institute of Medicine before a few years ago, came out with a report about reducing child poverty. And the data is robust that we can reduce child poverty in half in a decade and end up with more money than if we didn't do that. So that so child tax credits, for example, which were a part of what happened during the pandemic, food assistance services, a whole host of things. And what that report actually did was come up with like if you do this plus this plus this, you'll get this. If you do this plus that, you'll get this other thing. So it's a really great, and I can put the link to it in the chat in a minute, great report. And then the other thing is that we really, we have not as a nation signed on to a bunch of things that the United Nations set forth. So for the rights of the child, for example, we have not signed on to that. We've also not signed on to the rights for people with disabilities. And so those are kind of things that on a kind of political front, we're not engaging with. And I think there really needs to be a push to go back and really label these problems. And, the politics on this, the partisan politics of this are super challenging. And so it's, I think, some about it reframing in a way like this is keeping kids out of poverty isn't about free handouts. It's about making money for our country, right? So some of that, it requires some very serious reframing. But I think the being bold, something like, and Jim Perrin, a well-known pediatrician out of Boston, former American Academy of Pediatrics president, recently wrote, like, why have we not federalized Medicaid? Why don't we make sure all kids get EPSDT services in a way that isn't chock full of prior authorizations and denials and whatnot? Because it will be cheaper to operate it on a federal level than it is to do it the way we do it now, which is like, you've seen one Medicaid program, you've seen one Medicaid program, right? And that's not good for the people that it serves. And it's very, from an administrative perspective, adds complications that we don't need. I often think about, like, what is the thing we give? Oh, let's put in another care coordinator or another navigator. Why don't we just make the thing more simple? Like, that's like, let's not make it more complicated, make it more simple. And so I think there's a lot to be done, but we have to get rid of whatever perverse incentives drive things to be the way they are. And I wish I had a magic wand to do that, but I do think we need to be bold with, acknowledging the depth of the problems and where the solutions lie at fundamental levels of how things are organized.
It's interesting that the long-lasting legacy of the Grand Compromise still shows up today, especially in terms of how we provide healthcare for our children. Natasha?
Great. Thank you, Natasha Bonham, Genetic Alliance. Again, as everyone has said, wonderful presentation. I have 3 things that I want to comment on or note. I really appreciate that you spoke about family partnership and how important it is to hear from families and to really understand where the touch points that would make an impact in their lives and really getting into care. We, through our National Genetics Education and Family Support Center, recently brought together family leaders from across the country who are very active. And when we surveyed them, they only 22% said that there were enough opportunities to serve as family leaders in the genetics healthcare delivery system. So I think that shows that even our most engaged groups have struggles to really figure out, I have this passion, I have this energy, I have this opportunity, where do I put those efforts? So I think that just kind of aligned nicely with what you were saying around partnerships. I also wanted to note that though we talked a good bit about rural, me being here in DC in an urban environment, know that there are people who it takes over 2 hours to get to maternity care. That's 4 miles away because of how transportation is. There are a lot of efforts going in, but I think it's important to remember that, yes, there are definitely struggles in rural areas as there are in our urban settings and environments. And then lastly, and maybe this is something you can comment on if you would like, we often use the word universal to talk about newborn screening, and yet it isn't completely when we think about how every state has a different panel and what conditions are screened for are different. And it was I don't know if funny is the right word, but when you were talking about Medicaid, I was like, oh, that's kind of how we talk about newborn screening. If you've seen one newborn screening program, you've seen one newborn screening program. And, the work that Amy Gaviglio and Aaron Goldenberg and Beth Torini have done, and I think have presented to this committee, have talked about kind of the differences that we see. And we don't have to wait to see a child at 3 years old. Like the differences are from the beginning or even before the beginning, and how there are differences in state newborn screening programs, and then differences in the type of data we can get. And then it just kind of layers on from there. So just wanted to kind of bring that piece too. If we're really talking about equity and newborn screening, it's not just starting at the point where the family comes in, it's really from even before then. So, but again, thank you so much for your work in this presentation. And I hope we can get updates and refreshers on it, because it's really critical.
Well, thank you so much. And I love your point about, you've seen one newborn screening program, you've seen one. And, there are decisions that were made long, probably before many of us came to sit at these tables, about which ones were included, and then how do we act after one is positive, and those differ by states also. And those kind of where our priorities are deeply entrenched in our kind of cultural value and lens, right? That drive decisions about what we test for. Oh, this one's costly, but it's, very amenable to early intervention. Okay, so yes, we want to, what are the things that we use in our decision making about what goes in and what falls out, are all really culturally and politically mediated. And I think we all have to recognize that those things, like, well, we did this evidence-based thing, but that evidence-based thing is built on, lifetimes of inequities being baked into how we think and operate, and who has the power to decide things, right? So when you look around rooms of places where decision makers are, they often don't share my gender, and they also certainly don't share my disability status. And I have incredible privilege because of the color of my skin and my nativity, and that I English is my first language, and I come from a family of people who are educated. But we often do not locate our privilege when we assess evidence and data, and where that evidence and data came from. And so I really love the kind of what work needs to be done to do some equity alignment, even about what's included in newborn screening, and that making sure that people who come from typically unheard and oppressed groups are engaged in the evaluation of that data, and that we are taking a critical eye of what bias was already baked in, right? And what the structures of how things were done before lead us to conclude certain things. And it's hard, incredibly hard work, but I think it's necessary work for us to get to the place where we have our, full equity lenses on. And I really appreciate that point, because it talks about universal not being universal at all, and how when you call it that, it isn't really that. And I think naming things, calling it out, I think so glad you did that, because we have to do that. And a term like universal sounds universal, even when it's not. So I thank you so much for that.
Susan Berry.
Thank you so much for that presentation, which I found to be really enlightening about the honesty we have to have as we approach many of our areas. The comment I wanted to make was I was thinking about our discussion yesterday, and we're talking about Duchenne muscular dystrophy, and then we were talking about the definition of Duchenne and saying, and we should have a genetic definition. It should have a genetic test that matches with it. And I thought to myself, well, who's going to pay for the test? How's that test going to be done? It's expensive. How do we make sure that's truly available to every child so that we have an equitable and appropriate definition as well? I mean, it's just from the core beginning of what is the disorder. And that's also true as we think about adding disorders and say, we want to add this disorder because there's a treatment. It costs $1 million. How do we make sure that we think about that impact and make it as fair and as achievable as possible for all the babies? And so it's kind of, you talked about it being baked in. It kind of is baked in. Our science is way ahead of our ability to provide equitable care.
Yeah.
And we don't consider it as actively as we probably deserve to, as our patients deserve when we're considering those options in care. So that's my comment. It's not really a question. It's really an editorial.
No, I really appreciate it because, I take care of kids with muscular dystrophies in my practice. And, the kind of exciting things are these really new medications that are available that are just so life-changing. But, one of the things that, as someone who studied in public health, and it doesn't cost that much money to make sure people have some of the basic things that they need. And, the long-term consequences of poorly managed, underdiagnosed, treated conditions that relate to the reason those things happen is how we have biases baked into our systems and how we can't get families just the basic things they need to thrive in their communities. Also makes me think about which are the big talks about where and how we use our resources. Your other point is well, we need to have an actual diagnosis. When I started training, we were doing EMGs on kids with these kind of conditions to diagnose them. And now, thank goodness, we're not doing that. But we also have a serious problem in which, things like delayed speech is thought of very differently from a white upper middle class family's child than if it occurs in a Black family's child who are more likely to be poor. And then we just they'll catch up. It's a completely different discussion. And our kind of fundamental biases based in about those kind of things play out in very negative ways. And so, I really love the kind of thinking that we're doing here. And this group keeps, this is one of my favorite things is to have these kind of discussions and hear all of your guys' wisdom. And, our ability to hone in on one specific thing and then spread out the lens to see all of the bigger things and our responsibilities to the people that we serve to do that, to go deep on, let's say, muscular dystrophy, like you just did, and then pull out to see the bigger milieu, I think is the strategies that we need to use organizationally when we're having these kind of discussions. Even when that is a targeted discussion, we need to then blow out our lens and think much bigger. And so I really love the opportunity that you just, for me to be able to say that in response to something that's so near and dear to my heart in the place of muscular dystrophy and helping those families go through a situation that not diagnosis can be so incredibly devastating, but have, kids who have such full and rich lives, and that we help be as capable as possible. So thank you. I really appreciate that.
Michelle?
Everyone, thanks for that talk. It really brought home a lot of the things that we think about from the newborn screening perspective. And as part of newborn screening, the short-term follow-up piece, is sort of when that diagnosis is made and is that baby in care. And as Chris mentioned, historically, that sort of cuts off and then we go into long-term follow-up. So I'm wondering if as a group, newborn screening programs could think about how to build an equity piece into that and really track those factors down. APHL has some data from their New Step system that looks at time to diagnosis broken out. And there was a presentation to this committee, I don't remember when it was, showing that there are delays in diagnosis, even though programs get those results out right away. And I think it's really hard from our perspective to kind of look out and see or make changes to the way we do things in order to be able to improve that. But I think one of the most powerful things that you mentioned, to me at least, was this sort of the value of, the value added, right? So you, like you mentioned, you have a family, they miss their appointment, they miss work, they can't buy something, they can't pay a bill. There's all this trickle down. And I'm wondering if there's any way that I think the greater public can appreciate that more. Is there any way that we would be able to, make that more granular, I guess, and sort of show that we all suffer when people don't show up or when, parents have trouble getting to work or getting their child to an appointment. And I think really thinking about collecting better data from the long-term follow-up perspective can really help us with framing this to departments and get people thinking more about this rather than just throwing money at things and not really, like you said, stick it where it needs to be.
Yeah, ultimately, that's a money-saving intervention, is to not
Right.
just throw money at the problem and see, what comes out of it. And I
Right.
think, I think that this like linkage to what happens long-term. Obviously, the data is really important. And then how do we create the right bridge? And not everyone's going to need, the bridging from, the diagnosis and delivering of that information to the long term in the same way. And so, how do we tailor that in a way that meets people's needs and is not burdensome for people? And, I think also the messaging part is really essential as we think about the granular aspects, as the example that I'd given and that you brought up about attendance policies. Well, there's a whole bunch of incentives as to why attendance policies exist that way. And they have really negative consequences for families. And they also have negative consequences for, the system itself, and that it needs revision. But the other thing is that people really do, because all of us have experienced barriers to something like that. Our car tire got a flat tire when we were driving somewhere and we missed some sort of like thing that we were supposed to go to, or we're late for our granddaughter's wedding, whatever. And so, when we contextualize these things as more human experiences versus like, oh, well, I see that as a problem of this group, right? Because these are real, we all have universal, the word universal again, experiences where things don't go the way that we always expect them to despite our best intentions. And I think also kind of believing in our best intentions, even in the face of an inequitable and structured system that doesn't allow those best intentions to be lived, I think is really important, as for those of us in the space, holding on to the idea that it's not that, so-and-so's parents is trying to undermine my clinic by not calling me to tell me they're not coming. There was no malintent by them. They're not thinking, how could I ruin Dr. Houtrow's day today? But like, I think we also really have to hold on to, as people in positions of authority and people in the service space, is to really hold on to the kind of the kindness that comes with understanding people's best intentions and how hard it is to achieve them.
Thanks.
So Karen, we're at time, so I'm going to give you the last brief question or comment. You'll unmute.
You're on mute.
Thanks for that. I lowered my hand, but I didn't unmute. I really appreciated your presentation, and many of the questions I was going to ask were responded to in your response to other people. There are two things that I wanted to add to reflect on, and I think we're doing a good job of doing this. One of them is really around developing data systems that look at the systems issues more than all the data you showed from the National Service of Children's Health really is individuals' experience, but not really, what policies are in place that contribute to structural racism, for example, what contributes to systemic racism, and what are those measures? And I think we're starting to work on that. And so, I would really, again, thinking boldly, until we start being more refined at looking at the measuring structural differences and systemic differences, we're going to continue to go back to falling on, well, this person needs to eat better and that person needs, let's put transportation in for this family. And again, that's like pulling children out of the river downstream. So that is one thing. And I think I really appreciate how everyone is thinking creatively about systemic and structural measures that are not really based on individual measures. That's one point. The other point is that we've sort of danced around this and alluded to it, but I also think that we need to do a much better job of measuring and looking at implicit bias, and having everyone within the healthcare system, recognize that we do bring implicit bias, and that may blind us to our privilege, whether it's educational privilege, racial privilege, whatever privilege. And so I think I'm saying two things at the same time. One, we need to do a lot of internal work, all of us, and that that we need to look at the systems piece sort of at simultaneously. So
I love that, the causative nature of poverty on outcomes related to health and disability. It's like well-established causative relationship. And yet we don't really tackle it in show the associations with our data. There are a number of, people in power around the country who do not believe that there's any systemically embedded injustice in anything. And so I love the point of we need the data that demonstrates where the locus of the problem is, instead of focusing on the downstream differences and then trying to intervene there. And then also clearly very important is our own recognition that the world that we view. In another talk I show, do you guys remember a few years ago when the internet was
Dr. Howe?
Oh, you need me to wrap up,
I'm
huh?
sorry to interrupt because we have public comment next, and we could,
Okay,
I know we could continue to talk for a long time on this topic. I want to just pause and tell you, I know I speak not just for the committee members and the organizational reps, but everyone on the call, and thanking you for sharing your expertise, your considerable amount of time and guidance today. It's been great, stimulating, and you've given us a lot to talk about, a lot to think about, and hopefully a lot of things to act on. So thanks for your time today.
Thank you for inviting me and allowing me to be as long-winded as I was. I really appreciate it. And it was great to learn from all these people in this group who are very dedicated and wise, and I appreciate it.
Thanks so much. I want to move on now. We have 8 people signed up for oral public comments, and we will bring you on, ask you to unmute as we move forward. And we're going to start with Casey Felt.
Hello, and thank you to the committee for allowing me to speak on my experience with Krabbe disease. My name is Casey Felt, and I am a mom of a beautiful and strong Krabbe angel, Dawson Luke Felt. Dawson was born on July 16th, 2019, and he was absolutely perfect. As the months went on, my husband and I noticed Dawson never gained head control. He often got sick, would throw up his food, lost his laugh and smile, and eventually started having muscle spasms. After months of testing, on February 24th, 2020, we heard the words early infantile Krabbe disease for the first time. Hearing that he would not live past 2 years old brought me to my knees and made me scream in pain, devastation, and grief. My son passed away 8 months later at the age of 15 months old. My husband and I recently attended the Hunter's Hope Symposium, and what we saw amazed us. We saw children with Krabbe who were transplanted before symptoms living and happy. A 23-year-old who was transplanted at 3 years old was performing professional level magic tricks that stunned the audience. An 8-year-old who received a transplant for Krabbe disease just after birth recited the Lord's Prayer, and a 19-year-old who received a transplant as an infant sang "One Hell of a Amen" by Brantley Gilbert. I can only wonder if my son Dawson could have done these amazing things because Virginia never gave him a chance. Newborn screening is crucial for families to have that time with their kids. I only got 15 months with Dawson, what I wouldn't give to hear him say "Mama, Dada," or "I love you." You have the chance today to do something amazing, to give families time. You do not know how precious time is until you are given an hourglass and you are just waiting for the sand to run out. But with newborn screening and transplant, these kids can live. Thank you.
Thanks so much. I'd like to move on to Phil May.
Good morning. Thank you for giving me the opportunity to speak with you today. My name is Phil May. I live in Tennessee. This is my son, Dylan, who was born in 2004 and died just before his 5th birthday in 2009. Dylan was a beautiful, happy, sweet little baby who was, of course, loved unconditionally by me, my wife, and our two older sons. After starting to lose some motor skills, Dylan was eventually diagnosed with Krabbe disease at 8 months of age. For Dylan, that diagnosis came too late for any treatment. The doctors told us to take him home and make him comfortable until he died, and we should expect that to be between the age of 13 months and 2 years old. We were blessed that Dylan lived to be almost 5. During the more than 4-year period after his diagnosis, the disease progression was really unbearable to watch. We lost pieces of Dylan slowly and painfully. He lost the ability to move his arms and legs. He lost the ability to eat solid foods. He needed regular Botox injections in his legs to allow us to bend his legs enough to change his clothes. He regularly vomited his food after we spent hours each day trying to feed him. He was never able to speak. He experienced recurring seizures. He was often obviously in pain, crying out for long periods of time, and we had no idea how to comfort him. He lost his ability to smile, and most painfully for us, Dylan lost his eyesight. As painful as it was to watch the disease slowly take our son's life, our other sons, Jackson and Connor, and our daughter Sophie, who we adopted when Dylan was 3, all experienced this same loss. Each of them have complicated mental health issues related to the years of trauma from losing their brother in such a horrific manner. Had Dylan been screened for Krabbe at birth, I have no doubt he would be living today as a 19-year-old. I often, even 14 years after his death, envision what his life could have been had he been screened at birth and treated. We never saw Dylan go on his first date or graduate from high school, nor will we see him graduate from college, get married, or have children of his own. I'm not basing my confidence that he would be living today on what I've read or heard from others. I've seen with my own eyes many children with Krabbe who were screened at birth and treated. I've held them in my arms. I've seen them playing with other children. I've seen them laugh, attend school, and thrive. Without screening for Krabbe at birth, all of these children would have died a slow and painful death. And because so few states screen for Krabbe at birth, I know many more children who are in this excruciating process of dying at this very moment. I implore you to do all you can to ensure Krabbe is included on the RUSP. No parents and no children should ever have to endure the excruciating loss that we, our other children, and so many other families have faced. You have the authority to save the lives of children with Krabbe, and by doing so, you'll also be saving parents and siblings from experiencing life-altering trauma and the lifelong effects of such a devastating loss. Thank you.
Thank you, Phil. Next, I have Dietrich Mayturn.
Thank you, Dr. Kalanch, for the opportunity to return to the committee and speak again in support of the nomination of Krabbe disease to the recommended uniform screening panel. As you know, I have been very disappointed and frustrated with the outcome of last February's meeting. From the perspective of the nominators, including myself, which was outlined in the various responses the Secretary and you received since February, all available on the Hunters Hope website, it has been a surprise how negatively newborn screening for Krabbe disease was described. Yes, the early history of Krabbe newborn screening did not go as planned, but the committee did not consider the data in the context of the nominated screening strategy, which uses a biomarker cyclozine as a deciding factor whether a screening result is positive or negative. Cyclozine measurement was not clinically available until 2015, 9 years after screening started, and was first employed as a second-tier test for Krabbe screening in Kentucky, where it virtually prevented false positive results. Since then, 9 of the current 11 states screening for Krabbe disease use cyclozine. However, most states still struggle to abandon genotyping out of fear of missing a case. I believe that a public health program needs to balance the benefit of a few that need early treatment and those who are unaffected but could be negatively impacted by a false positive result. I think we agree on this point. So how do we improve this? If you consider the history of the ACHDNC, please remember the impact your previous recommendations have made. For example, for better timeliness, screening for tyrosinemia type 1, and of course, SMA. Without the committee recommending newborn screening for SMA defined as homozygosity for a specific deletion, providers would be inundated with helping stressed families figure out if their newborn is affected with this deadly disorder or just a healthy carrier. Just as in those instances, you have the power to improve newborn screening for Krabbe disease by adding Krabbe disease to the RUSP defined as reduced GALC activity and elevated cycosine. 32% of US newborns are already being screened for Krabbe disease, with at least one state, Minnesota, likely adding it within a year. Adding Krabbe disease to the RUSP as recommended would make screening for Krabbe disease equitable across the country, essentially eliminate false positive results, and give affected babies a chance at life. All this at a minimal cost because most states screening for other lysosomal RUSP conditions already measure GALC activity because a testing kit includes the necessary reagents. In summary, the nominated screening procedure for Krabbe disease is efficient and effective, and states already screening for Pompe disease or an MPS can easily add Krabbe disease to their panels. Relevant follow-up and monitoring guidelines have been published in peer-reviewed articles, and the NCC already developed and published act sheets, follow-up algorithms, and a knowledge nugget. Experts in the field working with patient advocacy groups stand ready at all times in support also of equity after newborn screening by facilitating timely and appropriate triaging of screen-positive newborns to ensure families receive the most up-to-date information to make the best decisions for their baby and their families. Therefore, I implore you once again to use your power to finally give all future US children with special needs due to Krabbe disease a chance, no longer condemning them to the suffering caused by this horrific disease. Thank you again for giving me the opportunity to speak to you, and I'm happy to answer any questions you may have.
Thank you, Dieter. I'd like to turn now to Joanne Kurtzberg.
Thank you, and hi, everyone. My name is Joanne Kurtzberg, and I'm a transplant physician at Duke Health. I've testified in the last 2 meetings, and I'm back today to share some new information about the nomination of Krabbe disease for addition to the RUSP. As you know, Krabbe disease was nominated in 2009 and again in 2021. Unfortunately, it was not approved to be added to the RUSP either time. Several criticisms were discussed, and we have attempted to resolve each one of them in a new and modified nomination, which will be discussed later today. First, ability to diagnose Krabbe disease through newborn screening was challenged, and as you've heard multiple times from Dr. Matern and in the evidence review, the addition of cycosine as a second-tier test for babies screening positive for low-GAL-C now enables definitive diagnosis of babies with the infantile, formerly called early infantile, form of Krabbe disease. Treatment of these babies with hematopoietic stem cell transplantation in their first month of life is life-saving and significantly improves the quality of life of these babies, children, and their families, which is a major justification and motivation for adding Krabbe disease to the RUSP. Another identified challenge was specificity of diagnosis of Krabbe disease through newborn screening. When we nominated Krabbe disease for addition to the RUSP in 2021, we included diagnoses of babies with the infantile, formerly called early infantile form of the disease, meaning disease presenting before 12 months of age, and late infantile, meaning disease presenting from 1 to 3 years of age as the nominated forms of disease. Diagnosis of babies with infantile disease was based on a positive screen and a cycosine greater than or equal to 10 nanomolar, while diagnosis of late infantile disease was based on a positive screen and a cycosine between 2 and less than 10 nanomolar. The latter category was divided into high risk and low risk groups based on additional testing with mutational analysis. We now recognize that the inclusion of the group of babies with intermediate cycosine created confusion and a lack of clarity around the diagnosis of Krabbe disease. It also had the potential to cause distress for families where a definitive diagnosis of Krabbe disease could not be confirmed. We also recognize that medical management of this intermediate group is not firmly established, creating more uncertainty both for newborn screening labs and among healthcare providers. To remedy this situation and also to enable diagnosis of babies with the most severe and rapidly progressing form of Krabbe disease, where early diagnosis is paramount to enable early treatment. We've now amended the Krabbe disease nomination for addition to the RUS to be restricted to infantile Krabbe disease alone. Infantile Krabbe disease can be diagnosed through a Gauss-C screen followed by second-tier testing with cycocine. Babies with a positive screen and a cycocine greater than or equal to 10 always have infantile Krabbe disease. The parents of these babies should be notified, rapidly counseled, and given the opportunity for urgent referral to a transplant center for workup for future transplant or gene therapy. Additional questions were raised about whether babies with infantile Krabbe disease referred for transplant during their first month of life really have infantile Krabbe disease. I can assure you that all of the babies with high cycocine have active signs of active disease in their first few weeks of life. Active disease includes white matter changes on MRI, abnormal nerve conduction studies, and elevated protein and cycocine in the spinal fluid, accompanied in some babies by changes in the EEG and auditory evoked responses. This information was published in 2005 and again in 2022 in 2 series reporting outcomes of transplant in babies with infantile Krabbe disease. As you've heard many times, babies with infantile Krabbe disease rarely gain milestones past smiling. They never develop head control or sit, crawl, stand, speak, or walk. Within a few months of age, they have feeding problems, extreme irritability, seizures, blindness, and spasticity. Babies who are transplanted in the first month or so of life never develop irritability, are cognitively normal, and gain developmental milestones, albeit at a slower rate than typically developing children. I personally have treated and followed over 30 of these babies, some of whom are now teenagers and living into their 20s. While I do not deny that some of these children have motor disabilities affecting their ability to walk, these children are happy, social, attending school. They have friends, they use computers, they can see, hear, read, communicate, and have a much better quality of life than untreated babies who suffer extensively only to die in a median of 2 years of age. As you will hear today, we submitted the revised nomination of Krabbe disease for reconsideration on the expedited pathway for addition to the RUS. The revised nomination restricts the diagnosis of Krabbe disease through newborn screening to the infantile form. Diagnosis of this form of disease can be accomplished rapidly with a Gauss-C screen and second-tier cycocine testing on screen-positive babies. If the cycocine is greater or equal to 10, the baby definitely has infantile Krabbe disease. Parents can be informed and given the option to be referred for further evaluation and treatment. This strategy will greatly reduce the suffering of these babies and their families who will otherwise experience it, as you've heard from many of the speakers today. Additional benefits include elimination of confusing results and unclear pathways for follow-up for risk of later onset of Krabbe disease, eliminates diagnostic odysseys for parents of affected babies, and provides access to genetic counseling. In summary, I strongly encourage the committee to vote today to allow reconsideration of the revised nomination for infantile Krabbe disease on the expedited pathway agreed to during this meeting. I also sincerely hope this reconsideration will result in a positive vote to add infantile Krabbe disease to the RUS in the near future. Thank you for your time today.
Thank you. Now I would like to call on Elisa Seeger.
Dear Chairman Kalanj and members of the Advisory Committee for Heritable Disorders in Newborns and Children, thank you for the opportunity to provide public comment. My name is Elisa Seeger and I am the founder of the ALD Alliance. Newborn screening advocacy and education are at the core of our mission, along with providing support to families affected by ALD, a disease that is not equally screened for in our country due to the disparities that exist in our country today. I would like to draw attention to the advocacy work that our coalition has been doing to end death by zip code. As many of you here know, the state where a baby is born determines which conditions they are screened for, leading to inequalities across the country. To end death by zip code, the country must prioritize complete RUSP implementation in all 50 states. We have consistently heard from state labs and the countless research done that funding is one of the major barriers to efficiently implementing newborn screening conditions. The CDC, under their Newborn Screening Quality Assurance Program, and HRSA both offered funding opportunities last year through grants intended to help states to build capacity to support implementation of the RUSP conditions. Today, as this community looks to the future with Duchenne and Krabbe in mind, I implore this committee to allot more of its time and resources to finding ways to fund our country's newborn screening labs. As a foundation that has lobbied tirelessly for the CDC's Enhancing Disease Detection in Newborns, Building Capacity in Public Health Laboratories grant, I applaud HRSA for the recent newborn screening Propel grant opportunity. However, there is a need to adjust this to take into account the birth rate in individual states to correlate with the funding that is available. One state looking to add MPS II, a condition recently added to the RUSP, estimated a cost of $750,000 to complete implementation. This state received approximately $345,000, about the same amount that all states were awarded. $120,000 of the $345,000 must be used for the state's follow-up program, as per the grant, and cannot be used for implementation, leaving the state left with $225,000, which will only cover 30% of their costs to add the new RUSP approved condition. We are asking our state labs to do the impossible. What purpose does the RUSP serve if states are not properly funded to add the recommended conditions? Many are so short-staffed that they cannot even designate an employee to apply for the HRSA and CDC grants. For this reason, I am presenting 3 asks today. Transparency. The CDC has a website dedicated to their grant program that shows the history of the grant, awarded states, amount awarded, and what the funding will be used for by the state. This allows organizations like ours to help target our advocacy and work with state follow-up programs to provide education to their newborn screening follow-up programs. We ask that the same be done for the HRSA Propel grant. Number 2, smarter funding. It is apparent that this new grant opportunity was put together with very little involvement from our country's newborn screening labs. Please include them in the process. $345,000 may be appropriate for some states, but the needs of our labs vary greatly across the country, as does the cost of implementing a new condition. Accessibility. As mentioned previously, many states do not have the resources to devote an employee to grant writing. It may be a skill set that is missing altogether. A 1-hour virtual meeting is not enough to prepare a lab to write a grant with personnel that has no experience writing grants. Grant writing workshops should not only be provided, but incentivized. It is already a difficult notion that labs should have to apply for funding to do their jobs. Let's make it as easy as possible for them to do so. We will continue to push for more federal funding for states and their newborn screening programs, and hope that state lab engagement in newborn screening process continues, as their voice and hard work is vital for ensuring that geography does not dictate life and death for newborns. I would be happy to help meet at a later date regarding these requests and share our thought processes as an organization that has dedicated much of our time building relationships with our state's newborn screening programs, the dedicated individuals that make newborn screening a reality. Thank you for your time today.
Thank you, Lisa. Next, I'd like to call on Dean Sir.
Yes, good morning. Thank you, Chairman and committee members and other attendees for this opportunity to speak. I appreciate your continued presence on our journey as we continue to work to bring early diagnostics and therapies to MLD families across the United States and around the globe. At our recent MLD Family Conference last month, we hosted our traditional butterfly memorial ceremony. We recognized and honored over 60 MLD family loved ones lost since our last gathering. Many of them would still be with us if we had diagnosed them pre-symptomatically. I'd like to give you a couple of quick MLD newborn screening updates. MLD Foundation started working with gene therapy researchers in Italy in 2005. We started working with the advisory committee to learn and to positively impact the MLD newborn screening ecosystem about 2011. About that same year, we started working with Professor Gelb on a MLD newborn screening assay. I'm pleased to share that MLD gene therapy was approved by the EMA in December 2021, almost 2 years ago. Again, the therapy was developed there. That's why the first approval was there. The outcomes for this gene therapy have been extraordinary, and many are saying curative. But as a rare disease, pre-symptomatic diagnosis is generally not possible without newborn screening, so most families don't have the opportunity to access that therapy. The FDA BLA, the biologics application submission, was completed over the past few weeks by Orchard Therapeutics here in the US. It has a rare pediatric disease and regenerative medicine advanced therapy designation from the FDA. The sponsor organization has requested priority review, which, if granted, would put the therapy on track for a potential U.S. approval the first half of 2024 next year. A publication recently came out last month or 6 weeks with an algorithm to determine the form of MLD using the baby's variant data and a genotype-phenotype scaling matrix. The authors are reporting a 76% accuracy across nearly 500 patients, and the matrix identifies how to deal with the VUS, the variants of unknown significance as well. This is really important because, as we've discussed and heard these meetings and plenty of other meetings, we need to know how to properly refer patients depending upon the form of disease that they have. We're adding advocacy and family experience to the scientific basis of this publication to increase the accuracy and expand some of those VUs and some of those conclusions. 76% accuracy is awesome. We'd love to see that in the 80s or maybe up to low 90s. The MLD RUSP nomination is very close to a formal submission to this committee. Adhering to your requirements to have an approved US FDA-approved US therapy, the nomination will be submitted roughly in sync with that anticipated approval. In addition, 4 babies have been identified to date through current newborn screening pilots that have screened well over 100,000 babies. So we've hit those checkoffs of the good therapy, the babies, and soon an approved therapy. RUSP alignment, I want to shift gears and acknowledge the progress of the Every Life Foundation and the many organizations working with them and the families that are participating in the process to advance RUSP alignment. RUSP alignment sets a time frame and or a process for a state to consider the review, in some cases actually to implement the screening of a new RUSP edition on a specific timeline. I was the catalyst for the language in California's 2016 Senate Bill 1095 that started their efforts, and I'm just thrilled with the progress they've made since then. In the last month or so, they passed Texas RUSP alignment, bringing the RUSP alignment state count to 11, covering 47.5% of U.S. annual births. Almost half of the country is covered by RUSP alignment at this point. In parallel, I'd like to give congratulations to the Illinois-based Evanosky Foundation, which brought a 10-plus year lysosomal disease effort to conclusion with the passing of Illinois Senate Bill 67, which gives MLD RUSP alignment-like status. So this is a singular disease legislation. With this legislation, MLD newborn screening, once approved, will cover more than 50% of the babies. About 51% of the babies will be expedited to implementation. I'd like to make a quick comment about the review process of the committee. Again, just to encourage additional consideration and thinking. You've talked a little bit about this yesterday. The newborn screening process is purposely optimized and focused on quality of life. Quality, of course, but also life. But I want to ask that you consider, what about death? Not just death and the negatives potentially from therapy, but death when there is no diagnosis or no therapy. Not all disorders are fatal or fatal quickly. MLD happens to be the infantile, late infantile form happens to be that. But death when you can't get diagnosis is death. And that's just a significant thing that you all need to consider when you do not review a therapy, or if you're looking at the positives, you need to add that to the negatives. So death should be part of that net benefit. Dr. Bailey, former member of this committee, published a new JAMA Viewpoint article this week with a core discussion focusing on net benefit. I'd encourage you to take a look at that document. And finally, the committee approved yesterday the review of DMD. We'll be talking about a re-review, an expedited review of Krabbe. There's reviews in process, and who knows what else will be submitted between now and when MLD comes on the docket. I remain very concerned about the expert advisory group's capability and capacity to handle multiple simultaneous reviews. They've shared that they can handle 2, but can they handle 3 or can they handle 4? And we need to keep thinking about that. There is a tsunami of gene therapies coming along. You will see a dramatic increase in nominations, and I'd like to help you and encourage you to consider your capacity. Thank you for the time to speak this morning. Appreciate your hard work.
Thanks, Dean. Now I'd like to welcome Kimberly Widener.
Good morning, and thank you for your time. I'm Kim Widener, and I currently live in Omaha, Nebraska. One of the worst days of my motherhood experience to date was the evening after my daughter Bailey received her diagnosis of congenital cytomegalovirus, or CCMV. That evening, when I was tucking her into bed, I sat with my 4-year-old daughter and explained to her that if she were to wake up in the morning and wouldn't be able to hear mommy, it would be all okay. We would get through it together. Bailey has single-sided deafness due to congenital CMV, along with balance loss, ADHD, brain calcifications, which we are still currently anxiously waiting to see how this will impact her learning as she matures. Bailey was not diagnosed with CMV until she was age 4, when she was able to tell me herself that she had a loud ear and a quiet ear. Her hearing was progressive when she received her diagnosis. We are still currently monitoring her other ear to see what her hearing levels will be. She now has 1 cochlear implant to assist hearing in her deaf ear. Congenital CMV affects over 30,000 babies every year in the United States, making it the most common congenital viral infection. 1 in 200 children are born with CCMV each year, which equates to 1 child being permanently disabled from CMV every hour. Common disabilities caused by CMV include hearing loss, vision loss, mental disability, brain calcifications, cerebral palsy, seizures, developmental and motor delays, and even death. More children are disabled by CMV annually than any of the other following congenital conditions: HIV, Down syndrome, sudden infant death syndrome or SIDS, spina bifida, fetal alcohol syndrome, group B strep, and rubella. Our family story is so similar to every other CMV's family that I have met through our journey. Why did we not know about CMV? Why didn't any doctor discuss this virus with us? I was warned about the impacts of kitty litter, deli meat, but never once was CMV, the prevention methods, and/or screening and testing ever discussed with us. I'm here today asking you and pleading for more to be done so future moms and dads and children won't have to unnecessarily battle the impacts of CMV for their lifetime. I ask you, if you were a new parent whose newborn was just diagnosed with hearing loss, only to find out that your child was exposed to a virus in utero that no one in the medical community warned you about, what would you do? Thank you for your time today.
Thank you. Last, we have Dylan Simon.
Good morning. My name is Dylan Simon, and I serve as the Director of Policy for the Every Life Foundation for Rare Diseases. On behalf of the Every Life Foundation, I would like to thank the committee for providing me with the opportunity to provide updates on our relevant newborn screening initiative programs. Every Life's newborn screening initiative is focused on ensuring babies receive life-saving treatment opportunities through early diagnosis with newborn screening. I'd like to thank the committee for providing me with the opportunity to provide updates on our relevant newborn screening initiatives, including 2 upcoming publications and our annual newborn screening bootcamp. The Every Life Foundation is dedicated to leading evidence-based policy efforts. As the committee may be aware, in 2021, we led the National Economic Burden of Rare Disease Study, and in 2022, published those findings in OrphanNet. That study included the largest survey of the rare disease community to date, which revealed an average diagnostic odyssey of over 6 years and 17 specialists and providers visited. Over the last 18 months, Every Life has been working with the Lewin Group to better understand the economic impact of the diagnostic odyssey in rare disease and any economic implications for early intervention. We are eager to share the findings of our newest study, The Cost of Delayed Diagnosis in Rare Disease, a Health Economic Study, in September. Of note, the study includes an assessment of the economic impact of the diagnostic odyssey in 5 pediatric conditions, including SCID, ALD, Pompe, Duchenne muscular dystrophy, and Fragile X. We are also happy to share that in the coming weeks, we will be publishing a white paper reflecting policies that were proposed as part of a newborn screening monitoring roundtable series last summer. The roundtable series brought together more than 100 leaders from a broad array of newborn screening stakeholders, including academic researchers, state public health officials, patient advocacy organizations, industry, and government officials. Together, we work to identify key actionable recommendations designed to achieve newborn screening modernization. Our hope is that these actions will help to transform the newborn screening system to remain one of the most successful public health programs. We look forward to working alongside you as we further develop these policy concepts. And now, a special save the date and invitation. We are delighted to share that the Every Life Foundation is once again partnering with Expecting Health for our 5th annual newborn screening bootcamp. Bootcamp will take place in person in Rockville on Wednesday, November 1st, just prior to the final fall advisory committee meeting. Our goal is to provide attendees with the opportunity to learn and discuss developments in newborn screening with experts and patient advocates currently navigating the newborn screening process, as we also work to facilitate engagement across our ecosystems. We appreciate the time and dedication of the expert speakers and community members who will be part of this event. Thank you for the opportunity to speak to the committee today and your tireless efforts on behalf of the nation's newborn screening families. Thank you and have a great rest of your day.
Thank you, Dylan, and thanks to all of the folks who have provided public comment today, and of course, those who shared with us yesterday. We appreciate, especially parents, bringing their stories forward in such a way that brings our work to life with real examples of the impact of these conditions on families and siblings and others. So I thank you for your time today. We do appreciate it. We listen intently, and it's a very important part of our process on this committee. At this time, I'd like to say that we'll take a 20-minute break. We're a bit ahead of schedule by like 3 minutes, I think. So we're doing well, and we'll come back in about 20 minutes. Thank you. So after the. Let's try to come back to the table. Or tables. Thanks, folks. I think what I'd like to do is just go through the revised slide sets on expedited review process amended after yesterday's discussion, and then we'll move on with the rest of the agenda. So can we bring those slides up? So you remember we talked about the background, that there might be a short time frame that would be sufficient to address issues with the nomination that was voted against by the committee. Next slide. And at this point, the nominators might choose to respond to address issues and submit new evidence or other revisions within the 1-year time frame. We believe the ERG could do an expedited review in an efficient manner, reading new evidence or just addressing other revisions without starting over. Next slide. So this is the process. Step 1, the chair sends a letter to the nominators summarizing the issues leading to the decision. And the current practice is this was within 2 months of the ACHDNC meeting where the decision was made. That starts the clock on a 1-year time frame. Within that time frame, nominators may resubmit a renomination package for an expedited review. Next slide. Requests for an expedited review must include responses to the chair's letter and may include additional new evidence or information on other relevant issues. The request must outline at least one material change and include supporting data or documents. Material change involves a change in scope of the condition nominated or substantial new evidence for the nominated condition. There is a change in scope, it's preferable there is also new evidence provided in support of the nomination. Next slide. So these are some caveats that I think we developed after yesterday's discussion. The package must address the committee's questions and comments in the chair's letter, but nominators must realize that the chair's letter only includes issues that were raised in the discussion. There may be other reasons a committee member voted against adding the condition. So we don't want to create expectations that addressing the issues in the letter alone will result in a changed vote for any one member. Next slide. The chair reviews the renomination package and then as necessary can reach out to both ERG and the nomination and prioritization work group and then make the determination if it qualifies as a material change. This step is likely to involve ongoing discussions with the nominators and will be performed as expeditiously as is practical for all participants. And we phrase this way without a time frame because it really depends on setting up meetings that meet the time frames and availability of all the parties that are involved. And we're worried if we define this or shorten it more succinctly, it could actually work against the process and kind of create unforced errors. Next slide, please. The chair concludes the renomination constitutes a material change. The package will be presented and discussed by the full committee for consideration for an expedited review. The committee should vote on whether to move the condition to an expedited review to be conducted by the ERG. If the vote fails, the chair will summarize the issues leading to the decision in the letter to the nomination group, and the condition will return to the list of conditions for future nomination and prioritization. Next slide, please. The chair concludes there's not a material change. The nominators and the rest of the committee will be notified and the condition will return to the list of conditions for future nomination and prioritization. Next slide. If the vote Passes, if necessary, the NMP work group will prioritize the review, considering other topics in the prioritization queue in order to determine timelines and deadlines. The ARG will follow standard systematic review processes to identify relative research published since completing the previous review. The ARG may find additional new research on issues not identified in the original review and committee decision and chair's letter that could impact the decision to recommend the condition be added to the RUSP. So that would be following kind of standard processes. Next slide. The ARG will work with the technical evaluation panel, revise the review to include the new evidence, and address any revision in scope. And this could involve additional modeling. When the review is complete, the condition will be scheduled for presentation, discussion, and vote for recommendation for inclusion on the RUSP at a regular committee meeting. A vote on the condition must be held within 9 months after approval of the expedited review. Next slide. Must be clear to all that a topic approved for expedited review may still not be recommended for addition to the RUSP. Next, it is the intent and expectation of the committee that this process will be engaged rarely for very few nominated conditions. This is not intended to become a routine process for most or even many conditions. And finally, recognizing that we need some experience with this, the committee will review and evaluate the process after 2 expedited review requests to identify and implement any appropriate revisions. So I think I've captured the thoughts of the discussion yesterday that you conditionally approved. And hopefully we can have, well, let me just open it up for questions and comments. Christine?
Yes, Ned, you did a great job of summarizing everything we discussed yesterday. I just had one question. So if you as the chair or future ACHDNC chairs decide that there is not an adequate material change or there's no change that exists, does that nullify the nominator from having a future expedited review for their package?
Yes, so the idea was we had to put I felt strongly we had to put a closure on this, and there is an ongoing dialogue that can last up to a year, but at some point there needs to be a decision that there's not a material change. So there's no time frame associated with that, but there ultimately needs to be a closure of the door to say we're not going to move ahead with the expedited review. Part of that is to protect our time and the time of the staff here, and to be clear with the nominators that the conversation is not getting to an end point. But you notice there was no time frame on that other than the full year. So, Margie.
Hi, thanks. I had a couple of questions. First, related to including new evidence. So if there's a change of scope and just like a narrowing of the scope, like I anticipate we'll hear later about Krabbe disease, that wouldn't necessarily require new evidence, just a change in how the previously reviewed evidence is being applied to the nomination. So I was wondering if you could clarify the idea of having new evidence with the expedited review request. That's one question. I don't know if you want me to give you all the questions or just do them one at a time.
Let me do that one real quickly. So yeah, the idea is that it needs to fulfill one of the 2 criteria, new evidence for the original nomination or a change in scope that's a material change. I did put in there that ideally you'd get both. So you change the scope and we're able to provide additional evidence, but that's not a requirement.
Okay, so that's kind of an and/or
Yeah.
statement. Okay. And then the 9-month, different parts in the Word document that was sent out, the timeline is more vague than 9 months at different parts in that document. So the 9 months starts from the day of the meeting vote rather than how does the 9 months relate to where something would fall in the prioritization queue?
Yeah, the 9 months is after the decision to do an expedited review.
Okay, and so I guess how it falls in the prioritization queue could shorten that 9 months, or it could extend it to the full 9 months, but not past the 9 months.
Yes.
Okay, and then last question. Thank you for taking all of my questions. I was wondering if you could comment on what sort of data points might be important in the review and reevaluation of this process once there's 2 expedited reviews completed.
Well, I think it's both. Were we able to meet the timelines? Are the timelines not wrong? Do they need to be readjusted? Give the nominators a chance to provide input as to how the process went for them, and see if there are any additional changes that would make it work better. I think we are also want to make sure that we are resourced appropriately in terms of staff and time and share time to make this work. And so figuring that out will be important data points to say, do we need to make any changes? I would also say that anything else that came up as we went along, I think recognizing that processes are, especially new ones, need to be piloted and tested. I felt strongly that we should do that for this one, and that 2 sounded to me like a good number to kind of take a relook at what things should be changed and how we could tighten it up, make it more consumer friendly or customer focused, and still keep it within the resource allocation that those of us on the committee and those of us who work for HRSA have available. So thanks for those questions. John?
Thank you.
Yeah.
Thank you. Sean McCandless, committee member. I think Marty's questions are very pertinent, but also kind of directed. They sort of emphasize a concern that I've had about this, which is that, I think it's right for this committee to try to formalize processes and make the process more clear, make expectations more clear for nominators. But at the same time, I want to understand what is the basis for these, like this decision we make today. What are we creating? Is this a guideline? Is this a part of our bylaws for the committee? Is this committing HRSA to something? I guess I'm not I want to be sure I understand what the level of expectation is, because I think that pertinent to some of the comments that Dean Sir made earlier, we may bump up against problems with timelines in the future if we create very strict policies about we're going to do this within this timeline. And so I just want to make sure that I understand what we are voting to create here, how it impacts us, and what are the mechanisms for adapting or adjusting if needed.
Yeah, I appreciate that, Sean, and trying to build in the flexibility. When we first put it out, other than the 1 year, there were no timeframes, and that was really to allow us to get some experience with it. Then there was a concern that this process, which was really intended to expedite things might be inherently slow. And so the 9-month timeline was borrowed from what the practice we currently follow for conditions that are referred to the ERG for full evidence review. So that's where that number came from. I think the one area of flexibility we gave ourselves was there has to be a vote. It didn't say that we had to vote up or down on the condition at that 9-month period of time. The vote may be to extend the time for later and trying to build flexibility in anticipation of problems that might arise. And then ultimately, I think we need to get some experience and figure out if this is a process we can do or can't do, given the resources we have available. Again, there are some concerns expressed that this would just be the way that groups do things. And in fact, it might have nominators come to the NMP work group earlier or before the research was robust enough to support a nomination, with the idea that they could always come back with a expedited review. And that's right, trying to set the expectations that this is rare. This is not a process for all topics. His expectation I tried to lay out in the caveats for the process. Sean?
Thanks. And just to clarify, this is not, is this binding in any way on the committee? Is this forcing us into, or is this merely an attempt to clarify and document how we intend to process a process that we intend to try to follow over the until we change the process? I guess, is there any formal meaning to us adopting this as a process? And maybe this is a HRSA question for Jeff Brosco. I get paid extra to put Jeff
Let me
Brosco.
just say, it won't show up in the bylaws because our processes aren't in the bylaws. So that's a kind of a different issue. But if we had a procedure manual, this would be a procedure manual. And we kind of have that with the NMP process and the pathways and the timelines and the other documents that support creation of a nomination package. I'll let Jeff answer and then I'll give you my thoughts.
And what Ned said is exactly right. And so what binds us are things like legislation. And if the committee decides to take a certain practice, it's something the committee can decide to change. And there will be, there are bylaws and standard operating procedures, and this falls toward the standard operating procedures, but it's an initial kind of, here's what we think we should do, and let's see how it goes kind of thing.
I mean, part of the thing, Sean, with the process now, I admit I'm putting a burden on future chairs because there's a lot of decision-making and work inherent in the work of the chair. And I actually think that's appropriate. It's trying to figure out a way for someone working directly with staff to think about the process and to be the point person. But you recognize there's like words like should vote. The committee could choose not to vote on an expedited review process. And so I didn't want to bind the committee to say, the chair thought this is a material change, it's bringing it forward, therefore we have to vote on it. I think making that should is are ways to say we're creating this pathway for exceptional topics, not that all topics aren't exceptional, but that there's something about the topic or the evidence review that makes offering this approach something that keeps us responsive to the needs of our advocacy communities. Michelle?
I'm Michelle Kajana, member. I guess I'm not clear on how long it takes for HRSA to do the cursory review when a package comes in the first place. Is that to kind of fend off the worry that packages will come in sort of incomplete or poorly prepared and cause undue burden downstream. So, yeah, I was just wondering, is it pretty obvious if a package, somebody trying to channel something in that direction would be obvious to the staff and not really be a big burden for everyone along the line?
The question is yeah, go ahead.
Michelle, you don't mean it, you mean a renomination package, right?
Yeah, I mean, if something comes in, so there's this fear that this expedited process is going to be used because people are going to come in at the beginning and try and circumvent the whole process. But I think the rules we set in place for this preclude that. But even so, if something comes back with a material change or extra evidence that's not strong, is that, I'm unclear, I guess, how much of a burden that will be.
So looking back historically, right, over the last decade, it is very rare for a condition not to be voted to the RUSP once it gets past the NNP work group. So the initial NNP work group has frequently said, no, there's not enough to move forward here, and sent things back. That's happened probably at least 5 or maybe as many as 10 times over the last decade. So you're right, there is that initial sort of leap that you have to get to just to get to the committee to vote for evidence review. What we're talking about now is once you've made it through all the way, there's been a negative vote. And then what I'll tell you is that there's a lot of back and forth between the nominators, the chair, and their staff to try to get to a point where we say, yes, there really is new evidence here. There really is a change. This is something that the committee is likely to take seriously. It's going to move forward. And the NNP work group and the ERG play a role in that as well. So if the nominators say, well, we'll have all these new articles, well, we can share them with the ERG and they could say, yes, this really is new, or you looked at all this, it's not really new. And the NNP work group can be very valuable because they can say, yeah, this change in scope really is a change in scope. This would change the way we think about things, or no, it's not really. We also wanted to make it easy because if a study came out that said, there's a brand new therapy, it fixes everything, the chair can just say, yeah, that's a material change. We don't have to go through ERG or NP. So there's flexibility built in to meet the many different possibilities of why a condition might come back for expedited review.
Okay, thank you.
Ash?
I'm actually in support of narrowing down the reasons why the reconsideration would be granted or an expedited review would be granted. And I'm especially, I think the change in scope or material change, that is one part, but the generation of new evidence within a year of the previous deliberation seems like that wouldn't be a frequent occurrence in my view. I think those are the kind of situations where it would have been better because research from the planning stage to the actual results takes multiple years, and most people in the field are aware of the results that are going to be coming down the line. It's better in those situations to just hold off on the nomination to a more suitable time if one is expecting positive results rather than submitting. I would certainly, I think those are situations we would expect would be extraordinarily rare, and that it's more often that the other side would be more likely to happen.
Right, I agree with you. So unless there are objections to what is in front of you as you voted on conditionally yesterday, and I've hoped to address the issues that came up, what I'd like to do is move ahead to present for your consideration a possible expedited review for Krabbe disease. So this would be our first one. Here's the summary of it. Doing this Krabbe disease renomination package. Next slide, please. We requested additional published data on the following topics: evidence review, efficacy of bone marrow transplant for infantile Krabbe disease that systematically reports outcomes and adequately classifies cases as early versus late onset, e.g. cytosine levels or genetic markers of infants transplanted. We requested evidence regarding harms of bone marrow transplant for infants transplanted in the first 2 months of life, including the possibility of transplanting infants not meeting criteria for early infantile disease. And finally, evidence regarding outcomes of infants who are at risk for late infantile Krabbe disease, as these children may experience even greater benefits than early infantile Krabbe disease. This evidence should include number lost to follow-up, potential burden on families and infants of intensive follow-up visits, and consequences of indeterminate diagnostic testing. Next slide. Again, material change has to be a change in scope of the condition nominated or new evidence. Resubmission should address committee questions and comments in the described in the chair letter. Next slide. You'll remember we voted not to recommend Krabbe for inclusion on the RUSP at our February 2023 meeting. Sent the chair to the Krabbe nominators in March. The disease nominators resubmitted the nomination package in discussions with myself and staff at HRSA in response to the chair letter. And that came back in July of this year. Next slide, please. I will just point out that we asked for the renomination package in anticipation of adopting a expedited review process. Had we not adopted the expedited review process, we would not have presented the renomination package. So I want to be clear that in an attempt to be timely with the nominators of Krabbe, we kind of staged this intentionally and would be doing things differently and ending the meeting early had we not approved the process. So asking the question, has it been less than a year since the ACHDNC vote? The answer is yes. Is the material change in the new nomination? My assessment of this is yes. The material change was the change in the target of screening to early infantile Krabbe disease, defined as onset within the first year of life, with reduced GALC enzyme activity and elevated cytosine in the newborn dried blood spot, represented a material change in the nomination. There were additional data provided that we reviewed with the ERG, made the conclusion that the additional data did not rise to the level of a material change, but the target of screening could change the benefit harm ratio, which is why I'm asking you to consider this today. Next slide. Those are the all items. Nice and short assumption. I think the decision on my part is material change. And now I open it up for discussion, remembering that the next step would be the committee considering whether to take a vote. And then I would ask if you do phrase the vote in the positive, that we would move ahead with expedited review. And I'll open it up to discussion, starting with committee members and then organizational representatives. We often say that one of the physician's best tools is silence. However, I'm going to see if there's someone who is interested in making a motion. If there is no motion, then we won't move on the consideration of this renomination. Ash,
Well, I move the motion to, for expedited review.
so is there a second?
I second.
It's been moved and seconded that we move Krabbe disease to the expedited review process based on a material change in scope of the condition. Now I'll open it up to discussion on the motion. Seeing no discussion, I would like to move to a roll call vote.
Thank you. And if you can just state yes, if you are in agreement, no, if you're not, or you can let me know if you choose to abstain. Michelle Kajana,
Yes.
Janine Cody,
Yes.
Cynthia Hinton,
Yes.
Christine Dorley,
Yes.
Paula Capacino,
Yes.
Jennifer Kwan,
Yes.
Ash Law,
Yes.
Sean McCandless.
I'm going to take the prerogative of the committee member to make a comment as I give my vote. And that is that I am going to vote yes, that this move forward. I do think that this is a substantial and marked improvement in the definition of what newborn screening would look for. I would appreciate going forward if it were clear that this committee is made up of people who are capable of understanding evidence and data, and that the evidence review group and the experts that work with them make a good faith effort to respond to questions and concerns. And I specifically would say two things. The question about our understanding of whether the addition of cyclizine reduces false positives. There's no doubt about that. But to continue saying that there are no false positives when the data presented show false positives, as happened in the evidence review and as it was seen in the new literature, regardless of the reason for the false positive and regardless of whether that is a one-off event, that's real life. And so please give us the benefit of being intelligent people and recognizing that there may be false positives. No one has ever asked that there be zero false positives for a condition. This committee has asked that false positives be balanced with the benefits of the treatment. The second point I would make is that again, we all look at the same literature, and when questions are raised about asking for confirmation that individuals that are referred to as having good outcomes from a treatment, that questions that are raised to show the evidence that those children truly have the condition up for discussion, and specifically related to Krabbe, to refer to older literature where molecular data are not available, where the diagnostic criteria that document the early infantile onset are not available. It's fine for someone to say, well, we know that these patients had it, but this committee is not expected to act on hearsay or on the advice of individual experts. And nobody would want us to do that. The data are the data. And if there is a request for data and a request for additional data, it would be greatly appreciated if that were honored, and honored in a respectful way. So with those two comments in mind, I vote yes to move this to expedited review.
Thank you, Sean. Kamala Mystery,
Yes.
Melissa Parisi,
Yes.
Janika Panpatkon,
Yes.
Jeff Brosco,
Yes.
and Ned Kalonj.
Yes. Thank you. The motion passes unanimously. Again, to clarify expectations, the strength of the vote does not indicate how we will vote based on the evidence review and presentation, which the clock now starts running on the 9 months.
And Ned, can I bring something up?
Yep.
Because I just got a text and I want to be absolutely clear. Organizational reps were allowed to speak. There wasn't any exclusion of organizational reps. And so if someone had anything they wanted to say, please, this was not I'm not sure I would think you'd be excluded, but no one was excluded. Okay. Thank you.
Thanks for helping me, Jeff, on that issue. When I see no hands on the screen, I take that as no hands on the screen. Sorry, I'm back to my notes. At this point, I'd like to ask if there are also this will be referred to the ERG. We will use ERG methodology, including a technical expert panel and the nomination and prioritization work group review as possible and as feasible and move forward in time. So at this point, I'd like to ask if there's any new business to bring up in front of the committee. I have Janine Cody with a hand up.
Yes, Janine Cody, a committee member. I was wondering if it might not be a good idea to have a presentation from someone associated with the National Academy of Medicine project to look at newborn screening and genome sequencing, and I don't know what their goals are, what their scope is, and I thought it might be, if others agree, a good idea to hear from someone associated with that project.
Yeah, I think, Janine, in my understanding that it's still early in the negotiation process. So while the money has been identified in the budget, it's still in process of talking about what the statement of task will be. The National Academy's work is dependent on that negotiated statement of task, which comes from a dialogue with the sponsoring organization and the leadership on the board to which the topic has been assigned. And so that will occur once the statement of task is formed, the committee starts work. There is no reporting out. It is a confidential process and it remains confidential up until the end. Now, that being said, the committee, National Academies, almost always includes public comment and open sessions to inform their work. When I did the PFAS study, we did town halls to actually make sure we gain the voice of the affected community across the country. And it would be my hope that as we set the new standard for community engagement for NASEM studies with that study, that would be also a process that was included in this one coming up. So I think we can have a presentation, but there are other things that have to occur before that would be possible. Oh, thanks. And I'm not involved in those negotiations, so I just know about them from my own experience. So, Natasha.
Hi, Natasha Bonham, Genetic Alliance. Now, two things that Janine's comments made me think of. I just wanted to update the committee that on June 7th, the National Academies did have their workshop on next generation screening. The promise.
And you were co-chair.
And yep. The promise and perils of DNA sequencing of newborns, and just wanted to let people know that the proceedings from that are up on the website. I did say that I would update this committee, and there will be a write-up on that. Happy to share any more information for anyone who would be interested in that. And then the second piece is, this concept of harms. keeps coming up. And I know that we've had some sessions that have kind of talked about it, but I wonder if in future meetings, we could delve more into that. I'm thinking of earlier today, kind of the message from our speaker of, to call a thing, let's put names to things. And it may be helpful to really revisit what does that mean and have some conversation, both about harms in newborn screening as well as benefits, since those keep coming up, but not necessarily the details behind those words. So just a suggestion, as it's a theme that, as I said, keeps coming up. Thanks.
I appreciate that, Natasha. And I think that is one of the topics that we hope to pursue with broader inclusion of families, advocacy groups, and experts as we think about a more detailed operationalization of decision-making supported by the matrix. So we've been talking around it, and I think as I'm talking with Jeff and HRSA staff, purposefully thinking about how we quantify, describe both harms and benefits moving forward to support decision-making is something we're all very interested in.
Yeah, and also, just not saying that you're saying this, but I think it isn't just a theme that just advocates or families need to understand, but we as a whole community and system need to understand, and need to understand where each of us, how we see that and can work together around those concepts. So thank you.
I appreciate that. And I wasn't saying just families. In fact, I think I didn't say just families, but that's okay.
That's what I said. That's why I wanted to echo that. So thanks.
Thank you. Jennifer.
I don't have anything new. I just wanted to thank Natasha for bringing up the important concept of harms, and also for trying to clarify what Sean was saying about harms yesterday. I think, Natasha, that one of the things that Sean may have been alluding to is that for certain people and populations, it is really hard for them to share their experience, their negative experiences of newborn screening. So this may be families who are, probably grateful that their child does not have a condition, and maybe that's as severe as the condition that advocacy groups are passionate about. It may also be medical providers who hear things that may present medical liability and are difficult to bring up because of the need to be, really discreet about comments that may, raise concerns about medical liability. Or just things that families do that have nothing to do with the advice they were given, but maybe just a misunderstanding of that advice. So it's always been a struggle for me to know where those that miscellaneous group of harms can fit in. But I think that they also occur, and they're more likely to occur with very rare diseases where treatments are in the hands of, relatively few experts. So I just sort of throw that out there in any sort of discussion of harms. I wonder if there could be room for those sorts of topics as well.
Thanks, Jennifer. Scott?
Not to belabor the harms point, but I think Natasha was just suggesting, and the back and forth after her comment reflects that there is a need for this discussion. And it needs to include diverse viewpoints and perspectives. And so I would encourage, based on just the feedback that you provided, Ned, and now Jennifer, I think it would be important to have that, and I would second that need for a discussion, particularly in light of some of the recent publications that have come out discussing not only this committee's, but in general, the weight of benefits and harms, and our entire system would benefit from it. So I second her suggestion.
Thanks, Scott. Are there any other comments or any other new business to be brought in front of the committee this day? Seeing none, as always, I wish to thank members of the committee, our organizational reps, other members of the audience, those families and other advocates and experts who bring their time forward to provide public comment. And then all the people at HRSA, without which there would be no committee, there would be no RUSP, there would be no ongoing work. The people that got me to Rockville successfully and hopefully will get me home, and who ride herd on our IT, including all the little glitches that we may have from time to time. I appreciate all the work that people sitting in the room with me do, as well as those who are outside of the room making sure things happen. And with that, I'd like to adjourn the meeting, but I will tell you our next meeting is in person in Rockville, November 2nd and 3rd, 2023. All of the dates through 2025 are listed on the ACHDNC website. And the May meeting of the Advisory Committee on Heritable Disorders in Newborns and Children is, sorry, the August meeting is now adjourned. Thank you.
Thanks, everyone.